Do we have Delegate Bartlett? Okay. Welcome to the Public Health and Minority Health Disparities Subcommittee. We have 6 bills today that we are discussing. The first bill, we don't have the bill sponsor yet, so we're going to give her one moment because she just texted and said she's hopping on. We're going to be starting with House Bill 863, Public Health Chief Medical Examiner Corrections to Autopsy Findings and Conclusions. And Rory, go ahead and let in the advocates, and we're just looking to see if we have Delegate Bartlett. Aaron, do you want to go ahead and talk us through the bill while we're waiting for Delegate Bartlett to join us?
Delegate Bartlett just joined the waiting room. So.
Oh, great.
This bill extends the time period within which a person in interest may request the medical examiner to correct findings and conclusions on the cause and manner of death from within 60 days to within 180 days after the medical examiner files those findings and conclusions. The bill sponsor did not offer any amendments.
And can I have a motion on this bill and then we'll discuss it?
Move the bill.
I have a second? Can I have a second?
Second.
Thank you. All right, the bill's been moved and seconded. Are there any questions or concerns, discussion on this bill? Delegate Chisholm.
I just want to make sure I got this correct. From what I read on the fiscal note, there's not a whole lot of corrections that are typically requested. So to move from 60 to 180 days really has very little effect on the budget. Am I correct on that?
Yes, according to the fiscal note, yes.
Okay, thank you.
All right, any other discussion? All in favor, say aye. Aye. Anyone opposed? All right, the bill passes unanimously. Thank you, Delegate Bartlett, for being here to answer any questions, and thank you for this great bill. We are going to move on to House Bill 283, Maryland Medical Assistance Program, Gender Affirming Treatment, Trans Health Equity Act. So we had a really robust discussion on this bill last week. We had our experts here to answer any questions. So Erin, if you can talk us through the bill.
The bill requires Medicaid beginning January 1st, 2024 to provide coverage for gender affirming treatment. It requires by December 1st of each year that each MCO submit a specified report to the Department of Health. And by January 1st of each year, beginning in 2025, the department is required to compile an annual report on geographic access to gender affirming treatment across the state.
And I'm correct, there are no amendments on this bill.
Correct.
Correct. All right, let's go ahead and move the bill. And
Move the bill.
Second.
All right, the bill has been moved and seconded. Do we have discussions? Any questions from the members? Delegate Riley. Followed by Delegate Chisholm. Delegate Riley, you're still muted.
Got it. Thanks. So yeah, I just wanted to kind of follow up on what we have here with some questions that we've asked previously. So there is no age in the actual bill. I know there was some discussion maybe putting the age 18 in there, but they said the bill sponsor and some of the people that had testified said that was not necessary. However, I know that that's still a concern with me because their answer was when we asked if this could be done, from the puberty blockers on, if this could, or the surgery could be done to a minor. Basically, that is yes, if it is medically necessary by the stating that, from the provider that it was medically necessary because of behavioral, mental issues or depression or suicidal, intentions or what have you. So, but at that point, they would have to have the parents' consent to do that. That is correct, right?
That is correct. Do we have advocates that want to speak to that question? I know we have the advocates on this call.
Yes, I'm here and Dr. Hedian is also here. And just to confirm, yes, parental consent is required for any medical care for anyone who's under 18.
Okay. And just to follow up on that, I understand that, but a lot of times, parents, don't necessarily understand medical terminology and so forth. But we had also, I think in the past had mentioned some testimony and some information that we found from other resources stating that a lot of, children in this category, have several other health problems, causes more distress, more suicidal attempts, and also getting, HIV, AIDS, all this other stuff happening to these children. But I guess that's okay with I guess this body and moving forward with this particular bill. I've just seen a lot of YouTubes and things of people that have had surgery, young and adult, and it just, they have a lot of issues afterwards. I know that, the panel that we've had on this bill says just the opposite, that they have a lot of problems prior to, and that's why we're, approving this. But I've just seen so much, that patients that are going through this type of surgery have further distress and further issues going forward into the future. So I just,
Dr. Heaton, I saw your hand.
Okay.
Do you want to go ahead and respond?
Sorry, I couldn't find the unmute button. Thank you, Delegate Bagnell. So thank you for the questions, Delegate Riley. I'm happy to try and address some of them today. When we talk about gender-affirming care for minors, it's important, I think, to be very clear about which populations we're speaking about. We often sort of lump children and adolescents into the same group when talking about this, but medically that's not necessarily representative of the care that transgender people receive. So transgender children are people who have not had any puberty development in their bodies. So transgender children, when seeking gender-affirming care, all that we're really talking about is connecting them with resources, providing them with support and mental health evaluations, and using the correct pronouns and names. It's just sort of all social affirmation. When we talk about medical care for transgender adolescents, so that's people who have started to go through puberty. Puberty blockers can be helpful for many patients. What we know about the research is that transgender adolescents who are able to access gender-affirming care, including hormone therapy, have mental health outcomes that are as good as their cisgender peers. And that's simply not true for adolescents who can't access the same type of care. You raise a lot of good points too about other sort of comorbid conditions and risks that this population faces. Each of those risks, and this is not just the opinion of this panel, this is what has been shown in the research, those risks are related to discrimination and social stress that people face. Well, minority stress is a well-documented facet that these people have to contend with. And so facilitating gender affirmation with parental consent, with the close care and guidance of mental health providers for people for whom it is medically necessary is absolutely beneficial for transgender adolescents. I hope that answers your questions.
Thank you very much, Dr. Hedian. Delegate Chisholm.
Thank you, Madam Chair. It was my understanding that there was going to be an amendment to this bill to raise the age to 18, but evidently it didn't happen. So when it comes to the puberty blockers, and there's so many studies out there, and I started to look into as many studies as I could, the vast majority of people that go on the puberty blockers, first of all, the concern with puberty blockers is, I know they say it's reversible. I think that's highly controversial on what the studies really say, but I think everybody agrees that it has an effect on bone density, one. Number two, the majority of people that go on puberty blockers then go to the cross-sex hormones, which have been proven to cause sterility, risk of breast cancer, uterus cancer, other psychoactive effects of high dose hormones such as mood swings and even psychosis. My concern is these are children, and I understand we're doing everything we can to protect them, to try to curb the suicide rate. But when we start to manipulate their bodies, when we manipulate your body in hopes of healing the mind, that's a very dangerous place to be. And knowing that, although most people are going to tell you that most of this is reversible, the studies are starting to pan out that that's not really the case. So, you know, this bill allowing puberty blockers for minors is, in my opinion, is an extremely dangerous bill, especially not having all of the science and all the studies confirmed and still being highly controversial. Just my point, Madam Chair.
Thank you very much, Delegate Chisholm. And I just want, before I open this to a response from the advocates, I do just want to remind the members that this bill was supported by Johns Hopkins, by MedChi, by the Maryland Medical Association, by the pediatricians. It has broad support from the medical community. So I just wanted to make sure we made that clear, and also I will give Dr. Hedian an opportunity to also respond.
Thank you, Delegate Bagnall, and thank you, Delegate Chisholm, for your questions. So to be clear, I mean, this bill, we're talking about care for minors. The bill is sort of larger than that. Gender affirming care is covered by private insurers. And so what we are talking about is not necessarily extending care to a group of people who wouldn't otherwise be able to access it. We're talking about making sure that people who are on Medicaid are able to get the same care that people who are on private insurance plans are. So we're not sort of opening the floodgates, we're simply trying to achieve parity from that perspective. And then you raised several medical questions, which I'm happy to address here. So the concern about bone density. So bone density there is more that we're learning about it as we go forward. What we know about transgender teens who seek care is that their bone density is lower before starting puberty blockers than their cisgender peers. So to be clear, these are people who have received no puberty blockers, who have received no hormone therapy. Their bone density is lower before taking medical care, and that's probably for a variety of reasons. I mentioned minority stress. You know, transgender teens are probably less likely to engage in school sports and activities because of the distress that they experience, which can be really intense and severe. When puberty blockers are not designed to be given forever, and when gender affirming hormones like testosterone or like estrogen are added after puberty blockers, the bone density is then built up. So the long-term risk to bone density does not appear to be concerning in this population. It is something that is being watched, but the medical research does not bear out the concerns about bone density. You raised questions about breast cancer and uterine cancer. To the best of our knowledge, hormone therapy does not increase the risk of either of these cancers. And then mood swings and psychosis. So hormone therapy, hormones, generally speaking, can certainly cause changes in mood. I mean, anybody in this world who has experienced a menstrual period or who has lived through a pregnancy and experienced the changes that come in terms of their mental health with fluctuating hormone levels can attest that, yes, hormone changes can influence our mood and influence our mental health. That does not necessarily mean that the changes with hormone therapy are negative. If they were negative, then in the research, we would see that people who take gender affirming hormone therapy had worse mental health outcomes. And we simply don't see that. I hope that answers your questions.
Yeah, but I think I want to focus on a couple of things you said there. You said these are things that we will continue to watch and we're still learning, which means we're still in an exploratory state of this is and I understand that we do this with private insurance. The big difference is we're now asking the public to fund through, the federal dollars and from the Maryland state taxpayers procedures that we're still quote unquote watching develop. And I think even you, being a doctor, understand that things evolve constantly, and we don't really know until we have a long period of study how things are going to turn out. I know we've been doing this in private insurance, but we're still kind of at the tipping point of how many people are entering into these types of procedures and this type of or puberty blockers we're adding. So I appreciate your answers. I'm once again just deeply concerned on what we're doing, but thank you very much.
And thank you, Delegate Chisholm. And just a reminder, once again, to the body, this is talking about a very small subset of our most vulnerable. Most of this bill encompasses our adult communities, not adolescent communities, but this is our most vulnerable on Medicaid. So it's a small subset. Mr. McAvoy, I know you have your hand up right now. I want to make sure that I'm addressing the questions of the members before we vote. So it's not that I'm not seeing you, it's that I need to make sure I'm hearing the questions from my members to get them resolved. Delegate Hutchinson.
Thank you, Madam Chair.
I'm sorry, Delegate Hutchinson. I'm going to interrupt only because I just saw Delegate Rosenberg actually has to testify in another committee. So let me go ahead and ask his question and I'll come back to you. Delegate Rosenberg, or did he leave? Oh, I think he just stepped out. Go ahead, Delegate Hutchinson.
Well, thank you. And I would always allow him to go before me because he's been here for 41 years. So, I've spent a lot of time understanding gender dysphoria. I'm very new to this. I've spent a lot of time with the advocates and I've learned a lot, and I can appreciate the challenges that our adolescents are going through who have gender dysphoria. And in all my discussions with bill sponsors or with their group, it was always said that the surgery would not be permitted unless they were below the age, unless they were above the age of 18. And yet the bill remains to be silent on that. Dr. Hedian mentioned that the private payers pay it, and they certainly do, but they have in their policies and their guidelines that surgery has to be above the age of 18. We have other bills, and we have a secretary of DJS who's saying that an adolescent's brain isn't fully developed until they're at the age of 24. And so I'm just perplexed as to why we remain silent on this age for surgery. If anybody could share or enlighten me why we continue to avoid that piece of this.
And I see both Dr. Hedian's hand and Pam Casemeyer. So Dr. Hedian, if you want to speak, and then Pam Casemeyer, if you want to speak as well.
Thank you, Delegate Bidnell, and thank you, Delegate Hutchinson, for the question. So let's talk about surgery. If we look at the number of transgender youth across the country, across the United States, there are 300,000 transgender youth. In the last year, 300 of them underwent gender affirming surgery. So that's 0.1%. The circumstances under which a person under the age of 18 obtains gender affirming surgery are very specific and nuanced. There are going to be patient factors and family factors that would lead that person and their family and their health team to seek gender affirming surgery under the age of 18. The reason that we don't have an age restriction on surgery in this bill, despite some of the concerns that you raised, is that we are aligning this bill with the international standards of care put forth by WPATH, the World Professional Association for Transgender Health. Now, WPATH, in their most recently updated guidelines, which were published in September of last year, changed a lot of things about care for adolescents in that they really emphasize the need to offer care on an individualized basis, recognizing that developmental stages are different, people's ability to understand and plan for the future are different, and their circumstances are individual. And it is, I would say, not safe. It's very difficult to paint with a broad brush and say that everyone under the age of 18 is not able to get surgery. Candidly, it's really quite challenging for anyone under the age of 18 to get surgery as it is, but to say that everyone who's 17 and a half, regardless of how they experience dysphoria and regardless of how it's impacting their lives, none of those people can get surgery. I just don't know that that's a decision that I would want put into law when the international standards of care are really very, are encouraging us to sort of take each person as an individual and to help the patient and the family and the health team come up with the best decision for them. But again, just as a reminder, like the number of youth who access gender-affirming surgery under the age of 18 across the country is a fraction of a fraction of a fraction, 0.1%. So we're not talking about a large number of people here. But I worry about the introduction of the age restriction for the reasons I've outlined.
Thank you, Dr. Hadian. Pam Casemeyer, did you have something to add? Or I see Sam Williamson. Go ahead.
Thank you. I just wanted to touch on the private insurance point. Delegate Hutchinson, you had brought to the last subcommittee a discussion of the Blue Cross Blue Shield Care First policy that says that surgery is not covered for those who are under 18. One of the pediatric doctors who was here at the last subcommittee, unfortunately treating patients right now, couldn't join us, told me that she knows at least one adolescent patient who was able to receive coverage under their policy. So there are certainly exceptions that are made under that policy. And we were able to see that Aetna and Cigna both do cover surgeries for those who are under 18. So just to be clear, that private insurances do cover these in some circumstances. Again, as Dr. Hedian said, it is very rare for anyone under 18 to request or receive these surgeries, but it is covered under private insurance.
Thank you, Sam. And I just got a text. Also, we do have an amendment to 283. Is that correct? That makes the MCO report discretionary.
Yeah,
And
Delegate
then-
Bagel, may I please go ahead and forward that to the subcommittee so that they can see it.
Thank you so much, Erin. Delegate Lewis.
Thank you, Madam Chair. I appreciate the discussion. I noticed a question that Delegate Chisholm posed that I'm not sure we answered, and I would like to make sure we get an answer for that. And as I recall, the question was, treating your mind by treating your body seems dangerous. And I think that was in reference, Delegate Chisholm, to the concept of using hormone treatment to resolve psychological, emotional problems. And I wanted to make sure, first that I got your question right, and then that we got an answer. And in my experience, as a person with a uterus who, has had periods for 40 years, and who's going through a variety of changes at my age, and I've come to learn through my own health providers that the use of hormone therapy is very common and appropriate for some women who are experiencing symptoms of menopause, which can cause emotional distress, psychological problems, and other mental experiences that are new and can undermine quality of life. So my question would be directed to Dr. Hedian, who I understand, if I recall, you did internal medicine, so you're not a gynecologist or specialist in women's health, but you went to medical school. And I'd just like, if you would be so kind and address the question of using hormone treatment broadly to address emotional and psychological issues in human beings, so that we know what we're discussing under this bill is not new, it's not experimental, it's not strange. It is in fact part of the arsenal of approaches used in clinical medicine. If that's all right, Madam Chair, if she could answer. Thank you.
Thank you, Delegate Lewis.
Yes, absolutely. Thank you.
Delegate Bagnell, yes. I appreciate your question. You're correct. I'm an internal medicine physician. I treat patients 18 and up. I think my oldest patient was 101. I have prescribed hormone therapy to cisgender patients and to transgender patients when medically appropriate. It is interesting, this concept of, is this treatment new? Is it exploratory or is it experimental? Estradiol and testosterone were discovered and manufactured in the 1930s and 40s. And so it is not new that we are able to administer these hormones. And really, we've been administering them since that time. As someone who practices in a scientific field, I think that I often sort of speak with caveats of, when I speak about this is a growing field, we are learning more, but that could be said for the field of medicine broadly speaking. We are learning more about cancer, and thank goodness that we are. But while we learn more about cancer, we don't stop doing treatments that we know work. We don't stop giving chemotherapy. We don't stop giving radiation. We don't stop doing surgery, because we have a robust body of research and clinical experience that tells us that those treatments are helpful, even if we could maybe do them a little bit better, because we always want to give the best care to our patients. Hormone therapy is safe. It is something that should be given in a medical context. But for the right patients, gender-affirming hormone therapy, both for cisgender and for transgender patients, can be medically necessary. I hope that answers your questions.
Thank you. I hope it answers Delegate Chisholm's question.
Thank you
Thank
very
you, Madam
much.
Chair.
Thank you, Delegate Lewis. Delegate Hill.
Thank you, Madam Chair, and thank you, everyone who's taken the time to speak with us today. I just wanted to be clear that I'm getting this right. We're talking about whether or not people in public assistance who, under the care of their physician, and more often team of physicians, have been deemed to appropriately qualify for treatments that happen to fall in the category of gender-affirming care, can receive it, and that in part of that discussion, the patients and their providers and their families, when appropriate, go through a discussion about options, risk, potential benefits, expectations, alternative treatments, cost, and all the things that in some sense we as a subcommittee are sort of discussing as if we can give a global answer as to yes, no, this shouldn't be done, when in reality, in practice, it is an individualized decision where the issues of, again, will I change my mind later? Could it cause me cancer? And all those kinds of things are discussed. And then that patient isn't being told, you have to have a particular treatment. They're being told, these are your options. And what we're trying to do with this bill is to remove, frankly, restrictions caused by economic status for what is not considered elective, but is considered medical treatment. Am I right about that? So I guess, Dr. Hadian, that's really directed at you.
May I answer the question?
Yes, of course. Thank you.
Thank you. That's a very good summary, Delegate Hill. Thank you. We are talking about patients who are experiencing severe distress, who can make an informed choice with the guidance of their care team, with the input of the people that matter to them. And as you said, none of these treatments is mandated for anyone, right? We are talking about making accessible care that we know to be effective for this population. And that's really what it boils down to. This is, as I mentioned earlier, it's difficult to paint with a broad brush and to say who will benefit from what specifically. And it's a decision that we'd like to allow patients and families and their care providers to make when it is medically necessary and appropriate for them.
All right, thank you, Madam Chair. That being said, I'd like to move the previous question.
Thank you, Delegate Hill. And we're actually going to move back to addressing the amendment. So thank you for moving the previous question because we do have an amendment. So I'm going to ask if Aaron can just define the amendment for us. So we'll vote on the amendment, then we'll vote on the bill. I just want to say to the members, thank you very much for a very respectful broad conversation on this. Remember, this is about equity and is about providing medically necessary services to our most needy Marylanders. With that, I'm going to ask Aaron to explain the amendment. We'll vote on the amendment. Mr. McAvoy, I will give you a moment to speak before we take the vote, but first we need to vote the amendment and then move the bill. So Aaron, if you can walk us through the amendment.
Thank you. I just sent a reprint to your email addresses if you'd like to pull up the reprint and make it a little clearer. So on bill page 5, beginning on line 3, there is a requirement that on or before December 1st of each year, beginning in 2024, each MCO shall submit to the department a report that includes, and this is the amended language, for each healthcare provider offering gender affirming treatment with which the MCO has an active contract and who consents to the inclusion, the name and location of the healthcare provider, the types of gender affirming treatment provided by the healthcare provider, and whether the healthcare provider consents to being publicly listed as part of the department's annual report that's required. On or before January 1st of each year, beginning in 2025, the department must compile an annual report on geographic access to gender affirming treatment across the state. And the report would include for each healthcare provider offering gender affirming treatment to program recipients and whose consent to the inclusion is indicated in a report that is submitted to the department.
Can I have a motion on the amendment?
So moved. Second.
All right, it's been moved and seconded. Is there any discussion? I see a couple of hands. Delegate Lewis, Delegate Hill, is this on the amendment? Delegate Chisholm?
Yes. I'm sorry. I just got the amendment and she just read it fast. Can you give me a quick summary, Aaron? What are we doing?
Aaron?
The bill is introduced, required each MCO to submit to MDH a report on where they're located and the types of treatment provided. This amendment just clarifies that the report would include for each healthcare provider that's offering gender affirming treatment with which the managed care organization has an active contract and who consents to the inclusion in this report. And then it would also provide for the option for the healthcare provider that's consenting, would allow them, they would have to consent to being publicly listed as part of the annual report.
But we would still be getting their data.
Correct. You still get it. They would just have to consent to the being publicly listed.
Okay. Thank you, Madam Chair. Thank you, Aaron.
Delegate Lewis, did you also have a question on this amendment?
Yes, Madam Chair. Thank you so much. I do have a question on this amendment. May I ask who is the maker of the amendment?
The
Is it
bill
the
sponsor,
subcommittee?
Delegate
Sponsor?
Kaiser,
Yeah,
and she did
is a
present it
sponsor.
at the bill hearing.
Thank you. And may I have a follow-up question, Madam
course.
Chair? Just to make sure I understand, are there other, is this an attempt to address the adequacy of the carrier networks of gender affirming care providers? Or is this, what is the motivation? Or is it an attempt to do something else? I'd really like to understand whether this is done with other forms of medical care.
Sam or Margot, would you like to speak to that? Go ahead. Sam, go ahead.
Yeah, so the original intent of the reporting requirement was to help people who are on Medicaid know which MCO would be best for them to enroll in so that they would know where their providers are in network. Because of the increase of harassment against gender affirming providers nationwide, many of the providers who are part of our coalition asked to make that report optional so that providers can make the choice whether they want to be publicly listed or whether they don't want to be publicly listed as providing gender affirming care.
And thank you, Sam. If I may have a follow-up. In our private insurance carriers providing information about clinicians who offer gender affirming care in their contract networks? Like, is Care First listing everybody who's doing gender affirming surgery?
A lot of that information is publicly available from the providers themselves on their websites. A lot of provider directories are general, so you might see this person is an endocrinologist. That doesn't really tell you whether they provide gender affirming hormone therapy. It tells you they know about hormones, but you don't know if it's specific to gender affirming care. And so that's how a lot of the directories typically work, but a lot of the information is publicly available directly from providers themselves. So this amendment would make it more closely aligned to that, where the providers are the ones deciding how much of this information is publicly available.
Thank you. Thank you, Madam Chair.
Thank you very much. And thank you for that comprehensive explanation, Sam. Delegate Alston, you had a question on the amendment? No? Oh, okay. Then let's go ahead and vote the amendments. All in favor, say aye. Aye. Anyone opposed to the amendment? Go ahead and raise your hand. All right, the amendment passes. Can I have a motion on the bill?
As amended.
Second.
Second.
All right, bill has been moved and seconded. Before we take the vote, I did promise Mr. McAvoy a moment he's patiently waited. So Mr. McAvoy, you have 1 minute to speak on this bill before we take our vote.
I want to ask that your committee members understand that people were waiting for this hearing and they had to drop off. You've spoken for an hour. I'll have a minute. So I'm going to talk about issues about autism. I know you're not going to have any questions for me. I'll send emails to specific delegates. This is a ship flying without
Mr. McAvoy, before
a
you
rudder.
start, I just wanted to confirm, this is the subcommittee. This is not a hearing.
Yep, I get that.
This is a subcommittee. So
I sure get that. I sure get
So
that.
go ahead. Go
Thank
ahead. You have one.
So I'm going to list some of the more tragic things because I don't have a lot of time. Okay, this is from Reed, the person who was working at the transgender shop where they were butchering children in St. Louis, Missouri. She said, we later found out this girl had to have intercourse because testosterone thins the vaginal tissues. Her vaginal canal had ripped open. She had to be sedated and given surgery to repair the damage. She wasn't the only vaginal laceration case we heard about. This is new. It is experimenting on children. This is making a ship as you fly it. Lack of regard for parental care and the constant discussion subcommittee regarding parents as basically being enemies. We are the nurturers and the ones looking out for long-term care of children. That cannot be done regardless of how individualized it's being said it is, and it is not. All of these things are being gender affirmed and not dealing with underlying issues of autism. There was a report just last week of depression, of overweightness. There was issues brought up by one of your proponents about not exercising. This is affecting the entire spectrum of how a child goes through puberty. The nonsense that this is just aimed toward adults, if it was, then they would put a cap on it. The fact is that Wisconsin has been declared a sanctuary for transgenderism. Why? Because federal money is at stake and being pumped into these states. And that's what's driving this, not care for children. I know care for children. I've been involved in this for 10 years of looking out for children as it respects family law and these bizarre operations and deviancies that are being promoted. These children are fine as they are. They need to stop being brainwashed through educational systems and through public health issues. We're saying, yeah, there's option A and B, but did you know there's also 51 others? And then saying, we have a course for you. This is child abuse. And again, as I said in previous testimony, Montana, Arkansas, and other states, Florida, are undergoing medical malpractice suits because of these treatments. Folks, they're not doing this because there's no case. There's a case. It just hasn't caught up with what's being perpetrated on our children. 8 states just this year have banned this entirely. Norway and other European nations are banning this. This state needs to stop this process. That's what I'll be telling the rest of the committee. That's what I'll be telling the House floor. It is
Thank you very much,
unconscionable.
Mr. McAvoy, for your patience and for sharing your concerns with the committee. I know we take this responsibility very seriously, and we really appreciate you being here to speak to us today. With that, I am going to call for a vote from the members. Again, this is, remember, we are voting on this bill, which addresses equity in medically necessary care for our most vulnerable. And with that, I'm going to call for a vote. All in favor for the bill as amended, please raise your hand, say aye.
Aye.
Anyone opposed, go ahead and raise your hand in the chat. I have Delegate Chisholm, Delegate Riley, and Delegate Hutchinson. Thank you very much to the members. Thank you for a really robust discussion and for making sure that we're listening to everyone. It means a lot. We are going to go to House Bill 1146, Maryland Medical Assistance Program, Adult and Pediatric Dental Services Review of Reimbursement Rates. Erin, if you can walk us through the bill.
A reprint of this bill has been provided that strikes the bill as introduced and its replacement language. So if you look on bill page 3 after line 9, the bill now requires the Department of Health, in consultation with the Maryland Hospital Association, to conduct a survey of hospitals to identify the availability of hospital operating room resources for dentist use, including the number of dentists credentialed at each hospital, the average time each hospital takes to credential a dentist, the number of operating room minutes made available to credentialed dentists at each hospital, the percentage of available operating room minutes used by credentialed dentists over the immediately preceding 12-month period, and any stipends paid for anesthesiology services related to the use of operating rooms by credentialed dentists. MDH and the Maryland Healthcare Commission, jointly and in consultation with the Maryland Hospital Association and the Maryland Ambulatory Surgery Association, must conduct a regional needs assessment for dental procedures that require anesthesia or moderate sedation, that must consider the survey on capacity, that was conducted by the Maryland Hospital Association, available information that can be used to assess capacity for dental procedures in ambulatory surgery centers, estimated startup and operating expenses for configuring and operating an operating room for dental procedures, and the ability of an ambulatory surgery center to pay stipends to anesthesiologists related to dental procedures. MDH and the Healthcare Commission, in consultation with the Maryland Hospital Association, must then develop regional plans to ensure the availability of appropriate operating room space for the performance of dental procedures for Medicaid recipients. And then on or before December 1st, 2023, the department and the Healthcare Commission will report to Senate Finance and Health and Government Operations, will provide a report that includes the results of the survey that was conducted under the bill, the results of the needs assessment, and also the regional plans. So that's one part of the amendment. Do you want to talk about that one or just go through the entire thing now?
Let's go ahead and vote this amendment. To the members, we have an additional amendment that we are considering, which Aaron and Delegate Hill will explain, but let's vote this amendment first, and then we can go to the sort of the second piece. If I can have a motion on the amendment. Should I have a second? All right, it's been moved and seconded. All in favor, say aye. Aye. Any opposed to the amendment? All right, it passes unanimously. Aaron, go ahead and talk us through the addition.
So the second piece of the bill, this is actually language that was House Bill 940 of 2019 that was introduced by Delegate Hill. And this bill this section requires the HSCRC in conjunction with stakeholders to study the feasibility of allowing for an unregulated space in a hospital operating room suite as a pilot project. The study would consider the factors related to the mixing of regulated and unregulated space at the hospital, which may include but are not limited to implications for all public, commercial, and independent payers of healthcare services, transparency for and parity of access by consumers to healthcare services, and interactions with hospital capital funding and capacity planning needs. It would also consider appropriate adjustments to a hospital's global budget revenue target for deregulating a hospital operating room suite, an examination of opportunities to offer unregulated operating room space for services that are not covered by insurers, financially responsible number of hospital participants in such a pilot project in context of the all-payer model contract, and possible criteria and standards for hospital participation. On or before, and it would be June 30th, 2024, the commission would be required to report their findings on the feasibility of the pilot project to Senate Finance and HGO.
And to the members, this particular amendment bill passed unanimously, I believe, both chambers, but then sort of disappeared on sine die. It just didn't make it across the threshold by midnight. Aaron, you have already spoken to MHCC. They're good with this, and it looks like, oh, and we have the HSCRC is here. Megan Renfro, if you want to go ahead and speak to the amendment.
Yeah, so I want to give a little history, which I have divined in the past couple of hours. So thank you, Aaron, for letting me see this. So there was that bill, HB 940. It ended up becoming a letter from the HGO chair to ask us to look at those issues. The language is a little bit different than this amendment. And we submitted initial findings from that. We had a work group and we submitted initial findings in our letter of information for House Bill, I should have written these out as talking points, sorry, House Bill 838 in 2020. And then we submitted a report in midway through 2020. And so that could be found at the Legislative Library. The language is a little different, but I'm not sure our findings will be that different. And so I guess my question here is to try to understand that is, I think some of the concerns we had about our federal regulations, about our contract with the federal government and whether that could be implicated by some of this, I think those stand. And so I'm just trying to understand how this fits.
Aaron or Delegate Hill?
Okay, so thank you, Megan. So let me just go back a bit. What we had tried to do with 940 was create a pilot study.
Mm-hmm.
And as the chair says, it passed both chambers, and then because of an issue with the hospital on the Eastern Shore, an amendment was accepted, which completely killed the bill. And I do remember the chair sending out a letter asking you all to look into this. I never received a report back on those results, so I will have to figure out how to dig that letter and that response up. I was contacted again by the original practitioners who were concerned that we are, because of the way the regulated hospital space is being used more and more, and I think that every member here can talk to people in their districts, surgery is being directed towards outpatient facilities based on the diagnosis and the treatment, and not based on the health of the patient. So in
can someone please mute?
Ms. Casemeyer, Pam Casemeyer, can you go ahead and mute?
And so there is concern that we are finding that we are not able to do right patient, right surgery, right location. And the hospitals feel like their arms are tied. So even when they have operating rooms that are open, that are staffed, and they don't have cases to put in there, they cannot put cases in there that are told that they have to be done because they won't get reimbursed or they'll be penalized for doing these cases that are supposed to be going to outpatient facilities. So one hospital in particular is interested in being the pilot and came back and said, please, 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 can you let us at least try this? I'm sure we can show you all that this is not only good for patient safety, but that it may help the bottom line and at the very least will not negatively impact it. So that's where
She
this
just
is
did.
coming from, if that helps. Because there was no pilot and we're still dealing with the same problems. They've actually gotten worse in the last 3 years.
So I think that's helpful. I didn't have that background or context before this meeting. But I do want to defer, I think, Nicole, I don't know if you want to talk about the hospital perspective here.
I think Delegate Hill is correct that there are restrictions based on regulated and unregulated. I think, Megan, the question you're asking is, will the HSCRC arrive at a different conclusion than you did in what was submitted before? And I obviously I can't answer that, but I will agree with Delegate Hill's summary of the discussion and limitations regarding regulated versus unregulated space.
And what we were hoping, if I may, Madam Chair, what we were hoping, and I didn't have a chance to look at the amendment, is that the amendment would create the pilot. So not a study where we just look at the numbers but an actual pilot where we can test and see. And as I said, we have a facility, at least one facility, if not more, who are willing to do a 1-year pilot to prove the concept.
This amendment adds House Bill 940 of 2019, which was a study.
Yeah. I think if it was to create a pilot rather than a study, there would be legal barriers to doing that. Right. With a study, we could discuss what those legal barriers are. But my understanding from my counsel right now is that we could not do this as a pilot right now.
And I guess that's how 940 got changed. So do you have, if I may, Madam Chair, does HSCRC have a suggestion about how we can go about trying to ensure that patients are treated in the safest way possible?
Right.
When our whole
Well, so I
tendency
think
right now is to do the other. So we can take a bariatric patient, for instance.
right.
Right, that's the best example. Because of underlying comorbidities, getting skin taking off is deemed something that we should be doing outpatient. And many of these people are people really who need to be monitored at least 23 hours of observation. And so the surgery needs to be done. It's being done where we're allowed to do it. And it puts everyone at risk. It's just it's not safe.
So I want to be explicit, though, that deeming is an insurance problem, right? That is what the insurance will approve as far as a setting. It doesn't have it. It is not because of how, I mean, it is related, certainly, right? HSCRC sets inpatient hospital rates and outpatient rates on the campus of the hospital. And insurance is certainly responding to cost. Right. But ultimately, it's insurance that's making that decision about where.
I think these are usually cases that are not covered by insurance.
With all due respect to our members, I think we might need to continue this conversation outside of subcommittee. Because it sounds like the study language isn't going to get to the
right, Madam Chair, I'll speak with. I don't want to kill Delegate Kippy's bill. Perhaps Megan and I can speak.
Absolutely.
Yeah, if we can speak offline, because just to the members, we have this bill and 3 others. So we're going to try and if Delegate Hill and Megan, if you can connect and see if we can work out the details. I would like to go ahead and vote on this amendment in the bill, but we will hold the bill and for a day, to see if we can work out the concerns. But we'll vote the bill and the amendment as they are now. Delegate Lewis, did you have a question on the amendment?
Sorry, Madam Chair, my questions can wait until whatever needs to get worked out gets worked out. Thank you.
Okay, All right, so we've already voted on the original amendment. Can I get a motion on the bill as amended?
Move the bill as
Move the
amended.
bill.
Second,
All right, it's been moved and seconded. All in favor, say aye. Aye. Anyone opposed? All right, and Delegate Hill, we will hold that bill. We have moved it as amended, but we'll hold it to see if we can work out the details on the other amendment.
Thank you, Madam Chair.
All right, that was 1146. We are going to move to House Bill 290, which is another dental bill. Erin, if you can go ahead and walk us through.
There's also a reprint of this bill that incorporates amendments being offered by Delegate Bagnall, the bill sponsor. Pages 2 through 4 of the bill require the Maryland Public School System, certain family care child homes and child care centers to provide notice to a parent or guardian of enrolled child of the clinical need for the child to receive a dental screening within 6 months of the child's 6th, 9th, and 12th birthday, and that the notice is to be provided 6 months before that birthday. Pages 4 through 7 of the bill is the Maryland Dent Care Program, which is a higher education loan assistance program, and the bill would add dental hygienists as being eligible for the program. That was part of the bill as introduced. Pages 7, beginning on line 17 through page 11, this strikes the language in the bill that would have prohibited the Secretary of Health from conditioning or limiting eligibility for Medicaid services based on an individual's citizenship or immigration status. On page 11, line 4, this requires the department to annually evaluate reimbursement rates for dental services. On page 11 also, this requires the department to create and distribute to dental practices plain language materials regarding the importance of regular dental appointments for an individual's overall health and various dental procedures as determined by the department, and to encourage dentists and dental hygienists to distribute the materials to their patients. On page 11, line 11, this requires the Board of Dental Examiners to publish a searchable list of mobile and portable dental service providers. Page 13, line 29 requires the department to study the establishment of a grant or no interest loan program for dental providers to open practices in underserved areas. And on line 10 requires the department to study dental provider participation in the Maryland Healthy Smiles program.
Thank you, Erin. And these amendments were consensus amendments that brought down the fiscal note, addressed the concerns that were brought by multiple stakeholders about a mandatory screening. It made it an educational piece. We moved some of the other amendments that were concerns to Maryland Medicaid into another bill. And so these represent consensus by all the stakeholders. Can I have a motion on the amendments?
Move the amendments.
Second, do I have a second?
Second.
All right, moved and seconded. All in favor, say aye. Aye. Anyone opposed? I have a hand from Caitlin McDonough. Go ahead.
Hi, Madam Chair. Thank you so much. And we're on behalf of the Maryland Dental Hygiene Association and some of the larger Medicaid providers in the state. We're very supportive of the amendments. The only thing I just wanted to kind of note for the record in the subcommittee is it's great to have Medicaid evaluate the reimbursement rates every year, but we've had budget language in to do that for the last couple of years. They haven't been doing it. And I don't know what evaluating them does if there's no kind of metric for them to evaluate it like in accordance with. So if this evaluation isn't tied to commercial rates or tied to some of the rate studies we see done by ADA or by the National Dental Advisory Service or something, I just don't know what that evaluation is going to accomplish. So I don't know if there's language that could be added to kind of clarify what they're evaluating, but I just wanted to flag it in subcommittee just for the record.
Thank you. I appreciate that. And Dan Doherty, I saw your hand go up.
Yes, I agree totally with what Caitlin just testified to. We have gone since 2010 with Medicaid rates being determined and evaluated according to Medicare. And as I've said several times, Medicare does not have dental services. So it's a comparison that is useless. And any increases we've gotten, which have been few and far between, have been sort of guesswork or arbitrary. And one of my real disappointments in 1146, I agree totally in the amendments as they relate to the hospitals, was the fact that there was no study to actually have a determination. What is the right yardstick to use in determining these fees? So I'm saying that as a general comment. I think the bill as the amendments proposed are great, but there's still a gap in this whole dental issue. And this may be the bill. I don't think so. I think it may be 1146, but I thank you.
Thank you, Mr. Doherty. I don't know that we just got a recommendation, other than we're not there yet. These are the amendments that came from that came from the advocate. So, Mr. Doherty, do you have a recommendation that we need to consider before we vote this bill?
No, Madam Chair. I think this bill is ready to vote. I just want the committee and the subcommittee to know we need to address that issue, hopefully sooner rather than later.
Got it. Okay, thank you. I appreciate that. All right, with that, did we vote the amendments? Aaron, okay. So on the bill as amended, do I have a motion on the bill as amended?
Move as amended.
Second.
All right, it's been moved and seconded. All in favor, say aye. Aye. Anyone opposed to the bill as amended? All right, the bill passes unanimously. I am aware of time because we are coming up on what is meant to be the start of our bill hearings, and I want to give everyone a couple minutes to get over to committee. Just to make you aware, we have two bills left on this list that we have not yet considered. Both of them still have a little bit of work to do. It's House Bill 1148. That's the behavioral health model for Maryland. We're still working on the CCBHC's piece. I don't think we have consensus yet, but we can check with Aaron to see if we want to do an update. And House Bill 318, the Maryland Medical Assistance Program, Provider Agencies and Personal Care Aides, Reimbursement and Wages. We are going to move both of those bills to another session. So make sure you are checking your email and your text messages because we're going to have another subcommittee meeting. I'm not sure if it will be today or tomorrow, but we want to make sure that we've got these bills ready to vote. So Aaron, did I miss anything?
Nope, I think you've got it, but just be ready because there's going to have to be a lot of subcommittee meetings and voting this week.
All right, thank you, everyone. Thank you. If I can have a motion to adjourn, and then we can head to our bill hearings.
So moved.
And I'll second it so I can get you all out of here. Thank you so much, everyone. Thanks for your hard work.